Hello, ladies. Let's talk about oral estrogen and blood clots today. Oral estradiol affects the liver, yes, but does it actually increase blood clot in the studies that everybody keeps ignoring? One of the biggest mistakes in the hormone conversation is confusing clotting factor changes with actual blood clot events. Yes, oral estradiol goes through the liver first. Yes, it can affect liver produced coagulation proteins. But the clinical question is not, did a lab marker change? The clinical question is, did women actually have more clots, DVTs, or pulmonary emboli with oral estradiol? And in several important studies using oral estradiol, the answer was no clear increase. In the Danish Osteoporosis Prevention Study, or DOPS, recently postmenopausal women were randomized to hormone therapy using estradiol-based treatment. Over long-term follow-up, there was no significant increase in venous thromboembolism in the hormone group. In the ELITE study, women received oral 17-beta estradiol with vaginal progesterone if they had a uterus. The trial showed that timing mattered for atherosclerosis progression. And importantly, oral estradiol did not produce a VTE signal that explained away the benefit-risk discussion. And in REPLENISH, which studied oral estradiol plus progesterone, there was one DVT among 1,684 women, and the participant had a family history of DVT. So the observed VTE rate was lower than what was expected annually for women of the same age. Now, this is important. Many of the studies that did show increased risk of blood clots used conjugated equine estrogen like Premarin, or combined the estrogen or estradiol with non-bioidentical progestogen, and that's a different formulation. It has different biological effects. To date, we do not have clinical trial data showing an increased risk of DVT or VTE with oral estradiol combined with oral micronized progesterone in appropriately selected women. So when someone says, oral estradiol increases clotting factors, my response is, that may be true, but surrogate markers are not the same as clinical events. Because really, what matters to the patient, what matters to me and to you, is not a theoretical change in a protein. What matters is, did it cause more clots? And in these estradiol-based studies, the signal was not clearly seen. Now, that does not mean that oral estradiol is right for everyone. I would still be cautious in women who have a history of prior VTE, thrombophilia, active smoking, uncontrolled obesity-related risk, or high baseline clot risk. But we need nuance. Now, here's where the confusion happens. Clot risk is higher with birth control pills containing ethinyl estradiol. That's a completely different molecule, higher potency, different dose, different purpose. Changes in lab markers do not always translate into real-world harm. So the takeaway is not that oral estradiol is risk-free. It's that we shouldn't assume risk based on theory alone. We should look at what actually happens to patients. Because when you look at real outcomes, the story is more precise than the fear. Thank you.